Hello, my name is Dr. Debra Patt. I serve as an Executive Vice President of Texas Oncology, and I'm a professor at Dell Medical School at the University of Texas at Austin. It's a pleasure to talk with you today about how COVID changed everything, specifically how the COVID-19 pandemic changed cancer center operations. Navigating operational change. We've seen changes in utilization of cancer services, whether it's screens, biopsies, surgeries, obtaining therapies, or even E&M visits. We've implemented guidelines and mandates, had limitations on surgical capacity, have staffing shortages, strains in the global supply chain, guidelines and mandates for vaccines and boosters, and some silver linings in telemedicine and virtual care delivery. Time Magazine aggregated a series of studies looking at decreases in screenings during the pandemic, missed diagnoses, delays in care in various aspects, and projected mortality. Myself and my colleagues worked with COA and the Avalier Health to characterize the Medicare population in the United States, where we took the 5 to 7% population and looked at utilization characteristics in 2019 in contrast to 2020. What this slide shows us is a 7-day moving average of COVID-19 positive cases as the area under the curve. And the red line is breast, colon, lung, and prostate cancer screenings, with the blue line being, black line being E&M visits. What we can see is inversely proportional to the COVID-19 rates across the United States, screens and E&M visits were decreased substantially. We observe anecdotally that this is still the case. Broken out by cancer type, mammography, colon screening, lung screens, and prostate cancer screening, you can observe that with 2020, in contrast to 2019, utilization was substantially reduced in March through November of 2020, in contrast to the preceding year among Medicare beneficiaries. Similarly, cancer-related biopsies were dramatically reduced during this time: breast biopsies, colon biopsies, and lung biopsies. And not surprisingly, cancer-related surgeries have decreased during this time. We know the natural consequence of lack of screening and lack of biopsies and surgeries is that cancer will grow unabated. This will result in a stage migration and heighten cancer morbidity and mortality for many years to come. Obviously, this is an opportunity for all of us to heighten awareness among patients and our primary caregivers of the importance of having screening in preventative health care. We've all also been struggling with implementing guidelines and mandates, masking, screening, staying 6 feet apart, limiting capacity in our clinics, taking out chairs out of our waiting room, restricting visitors, which sometimes means not letting caregivers come in, even with a new cancer patient diagnosis, procuring PPE, managing exposure and risk among our patient population and among our staff. We've needed more staff to implement these changes. We've had to spend more expenses on these various changes. We've had to navigate vaccine mandates. We've had to think about communication differently. And our patient population has had greater needs, with more anxiety, depression, and fear, facing more barriers as they try to obtain their own health care. And this poses a greater burden on staff. I would say of all these, while there have been many challenges in the last 2 years, the greatest has been communication. As an organization, we've really thought about this differently, thinking about implementation of town halls, of web-based communication with staff and patients, emails, newsletters, various different strategies to facilitate communication. But this, and setting expectations, has been very critical as we've looked at how guidelines and our management has changed over time. It's especially true when thinking about surgical planning, because once a patient learns that they have a cancer, they anticipate the cancer will be removed surgically. When that is not the case, because we've had to alter our surgical guidance because of the COVID pandemic, this requires a lot of expectation setting with patients. Frequently, surgical planning had to be altered during the COVID pandemic because of changes in capacity at the hospital. If the hospital had high rates of COVID or high rates of ICU admissions, then frequently surgeries had to be delayed. Our national guidelines, whether it was the American Society of Breast Surgeons, CMS, the American College of Surgeons, were very good at giving us guidance and policies and how we thought about approaching patients that maybe couldn't go to surgery just now. This involved a lot of multidisciplinary treatment planning, and frequently patients were managed differently, whether it was initiation of neoadjuvant endocrine therapy or even altering the surgery somewhat to try to allow them to get what they needed when they needed it. I'm really proud of the multidisciplinary treatment planning that went on during this time. I think it represents a really important pivot for cancer centers. And again, I think a critical aspect here is patient communication and organizational communication, as we need to set expectations. Otherwise, it can be incredibly frustrating and fear-inducing for the patients we serve. We were undergoing a staffing crisis before COVID-19 had ever been before the pandemic ever initiated. But the pandemic has been a catalyst for the staffing crisis, particularly the nursing shortage. I anticipate this will be a burden for many years to come. Up and above that, there's been the Great Resignation, which has provided staffing challenges in many of our practices. And then there are competing crises, because if there are individuals who are working and outside of the home, but have children at home or others at home that then need more care, frequently that pulls people out of the workplace. For example, if you have children that don't have childcare or have education now at home, and that has to be monitored, that's taken many individuals out of the workforce. We've managed this differently with bonuses and thinking about transitioning how we work. Are we going to have altered hours in our clinic? Are we going to offer different bonus compensation packages? And can we work differently? Are there opportunities for virtual staffing? I will say, despite having many open nursing positions throughout our large practice, when we hired for a virtual care delivery clinic, that was easy to recruit for because people are excited to be working in that way. We've also faced many challenges in the global supply chain, with limitations in PPE procurement, shortages in chemotherapy. For example, this last month in dacarbazine and Abraxane, limitations in procurement of intravenous fluids, electrolyte replacement, and even laboratory supplies. If we can't get test tubes to check CBCs and CMPs, then it's hard for us to deliver chemotherapy if we can't monitor toxicity. This means we need to think about that differently. Are there ways in which we can stabilize our supply chain? Is there a way that we can get distribution nearby? Can we think about sourcing more locally? So this is a challenge that I think will persist for many years and has been a major challenge during the pandemic. There are some silver linings: telemedicine, electronic patient-reported outcomes, virtual care delivery, virtual support groups, multidisciplinary tumor boards delivered virtually, and alterations in staffing models. Telemedicine grew rapidly during the global pandemic. Here in the United States, there were policies federally and at the state level that allowed for this to happen, that made it legal and also paid for. Both of those led to an increase in adoption of telemedicine. During the global pandemic, we've been providing 10 to 15% of our new cancer patients and 15 to 20% of our established patients visits by telemedicine, which has been remarkable. And I think this will be something that continues, probably not to that level, but something that continues as we evolve to support patients where they are. In addition, we've implemented electronic patient-reported outcomes for symptom management. This is in contrast to the standard approach to symptom monitoring, which is subject to recall bias, limited time in the office, and causes delays. When patients are able to engage with digital platforms or applications, they're able to have symptom control where they are. We implemented electronic patient-reported outcomes during the global pandemic among patients that were undergoing new cancer therapy, and this was a successful way to have them get just-in-time symptom management. It's some of these silver linings in digital healthcare that I think will serve us for decades to come. And in this way, the COVID pandemic has been a catalyst to improve care delivery. I hope that's helpful as we think about how to navigate the future. I think many of these challenges will be here for years to come. and I hope we can learn together. Thank you for allowing me to participate today, and I'm happy to take any questions.